view, Farhad.
Excuse me?
You're teasing us with this view.
It's closed, unfortunately. We can't go up there, but hopefully it's open again, I think in summer. It's the Jungfraujoch, yeah. So these are my financial interests for this very specific topic. In fact, we had the rounds 1 or 2, which were more of the background. The third part of the lecture on irregular corneas mainly is cases, simply interesting cases. And this makes it a little harder for me because usually I can interact with my audience directly, but here we are all virtual, we're sitting in front of our computers, so I cannot play with the audience and get the feedback. But each case has a deeper meaning, and in some cases we will take the opportunity to dive a little bit more into what can be done. Let's just start with one of these cases. Say a 20-year-old man who comes referred by the optometrist because visual acuity was quite low. He presented with the visual acuity you see there, so 20/200 and 20/60. Never wore glasses or lenses. And even in Switzerland, this happens on a regular basis. So looking then at the topographies, we received topographies from the referring optometrist. So this was in November 17. And this is 8 weeks later. So no corneal warpage, young patient never had contact lenses. So an increase of 3 diopters of Kmax in 8 weeks in a 20-year-old. And I think the message here is clear. If you are young, you are sometimes in a very aggressive state of the disease. And if we see such young patients with a clear deterioration, then first of all, many of us would probably take the opportunity to cross-link the patient immediately. But if for whatever reason you see a less pronounced cone in a teenager and you decide to wait, 8 weeks or 12 weeks might be a little bit too long. I had patients who increased 2.5 diopters in 12 weeks, similar to this one. So please keep the first interval at 4 weeks if you decide to see a very young person again for a follow-up. Do not wait too long. You can always increase the intervals afterwards. And a second case, a young woman, 30 years old, and she had been wearing contact lenses for more than 15 years. And I cannot recall the exact cause of why she wanted to come to see us, but it was most probably due to a certain decrease in visual quality and acuity. So what we tell all our patients is, please stop your lenses for 2 weeks. Gas permeable lenses, but also soft contact lenses. So 2 weeks should be decent. Now look at this topography. This is the Scheimpflug image after 2 weeks without the contact lens. Now looking at this cornea, simply by looking at the upper and the upper Kmax readings and the lower Kmax readings, you would say, oh yeah, I don't like this too much. This I can believe that the algorithm of the Pensachem classifies this as a cone grade 1. Now we had the patient come back and wait another 2 weeks without wearing any lenses, and look at this. So still there is an asymmetry, but the asymmetry, the color grading suggests that there is a greater asymmetry that there is. But if you look at the pure numbers, you have a difference of maybe 0.1 or 1 diopter of a difference between the superior and the inferior cornea. And all of a sudden, the algorithm doesn't detect a clear cone anymore. This just to show you that 2 weeks of contact lens cessation, of course, is the maximum we can ask from our patients in daily life. But still, there is warpage after 2 weeks. There is also warpage after 4 or 8 weeks. And anybody dealing a lot with cornea and contact lens wearing patients knows that. But we have to remind ourselves sometimes that the rules we set, they do not mean that 100% of our patients will come with a perfectly unaffected cornea by contact lens warpage. Warpage is always a part of our consideration. So these are, I think, are very straightforward messages. Now, yeah, and this is where the interaction with the audience, let me just see whether there are questions popping up. No, I don't see any. Let's take another case. A 27-year-old man who came to see me not too long ago. I think it was a year or 1.5 years ago. This is the refraction. So he clearly has an issue on the right eye. The right eye is at 20/40 of vision, the left eye at 25/20. And look at this Scheimpflug image of the anterior surface. Looking at it, I would say, okay, yeah, this is quite a clear ectatic process. 20/40 vision, I would have maybe expected a little more just out of experience, but this is incongruence. Now, this is the anterior surface. This is the anterior elevation. I don't look at this too often, but now look at the thickness. Thickness is at 260. And this is quite in contrast to the clearly visible but not very, very dominant cone on the front surface. And if you look at the back surface, we had almost 200 microns. So a huge discrepancy between the anterior and the posterior surface. And I've maybe seen a handful of these cases where I'm very, very surprised looking at the posterior corneal data. This is something, of course, we should keep in mind, because now I perfectly understand the visual acuity of the patient. The visual acuity is not defined by what we see on the anterior surface only. It is, of course, also defined by the posterior surface. And anything we do on the anterior surface, might it be a contact lens, might it be cross-linking with a flattening effect, away from guided PRK, it will still leave us with this posterior elevation. So if you ever plan a combined procedure, cross-linking plus PRK, Athens protocol, Cretan protocol, or sequentially, well, don't promise too much to this patient, because you might do a fantastic job on the anterior surface, but you will still be left with the posterior surface. This is just a reminder. And this is the OCT image, the MS39 image of that particular patient. Good. Let's go to the next case. That's the 48-year-old man. And again, you can see there's an issue on the right eye, visual acuity, CDVA on the right eye is 20/60. Left eye seems to be really good. Let's have a look at the topographies. A very distinct cone on the right eye, and almost nothing to see on the front surface, on the anterior surface of the left eye, but a corneal thickness clearly below normal ranges on the left eye too, but it is a very, very unilaterally heavy case of a cone on the right eye. And now you won't be surprised if I tell you that the patient is a massive eye rubber. Now it's getting interesting. A massive eye rubber. Let's look into eye rubbing a little bit. We had lengthy discussions about eye rubbing in the last years, and there are some things I fully agree with, and there are other things I do not fully agree. Let's have a look at eye rubbing, and this is where I will dive a little more into the data, and I will show you some slides that some data that has not been shown yet, because we will only present it at ESCRS. Now, if I show you this one here, if this is eye rubbing, what the gentleman does, you see he started eye rubbing, and at a given moment he stops the stimulus and nothing really happens. The system stays as it is. And this is what I believe eye rubbing is. Eye rubbing is a trigger. And if you stop the trigger at a certain moment without passing a threshold, then I do not believe in keratoconus onset. I believe that eye rubbing is very dangerous, and if you do it for a prolonged time, for very long, then at some moment the disease will start, and then the disease takes its course, whoever is rubbing or not. And this is what I believe. You need a trigger and you need to pass a threshold. And here it goes. So now, whether you rub or not, the disease will still continue. But if you stop at an earlier point in time, the disease will not go on, or the disease will not even come to the surface. So I believe that eye rubbing is a trigger, not the cause of keratoconus. I believe it's a trigger. So what I tell my patients, stop eye rubbing, yes. But stop eye rubbing and all your problems are solved? Definitely not. And we have been looking a lot into this in the past 2.5 years. And one of the first things I've realized is there are very strong social media campaigns about stopping eye rubbing. And my friend Renato is doing one, which is excellent. This is exactly the message we have to convey. What I do not agree about is that you stop eye rubbing and everything else will settle. No, eye rubbing is just a trigger. And if you look into PubMed on the impact of eye rubbing on the eye, all you will find is a handful of case reports. So there is no research. There's nothing there to show us the real impact of repetitive rubbing. I would like to know as a clinician, is my patient at risk if he does this 5 times or 50 times? Or does he need to do it 500 times a day before it becomes a risk? I would like to know that. So we started doing some research into it. And the first one was very simple. What we did, I think we are at 60 patients now. We simply asked patients to perform the typical eye rubbing movement on a high precision scale. And the only value we wanted to have out of this was how many newtons, how strong does the patient rub, nothing else. And we received these data, and there is no surprise that when you use your knuckle, you will apply more force, the fingertip less, but it gave us values. And why do we need these values? I'll show you why. Let me skip over the next slide. We need these values because we built an eye rubbing machine. Don't laugh. We built a machine that rubs the eye repeatedly. It took us more than a year to build that machine. You see this older gentleman, he is a genius. He's a retired engineer who is repairing steamboat engines in his now in his retirement, but he's able of thinking outside the box. And he built us the device that you see here, a device that has a vacuum pump to hold an eye in place, even an eye, a whole eye with a lid. And then we can adjust the force by which the simulated finger rubs the eye by 1/100th of a Newton. And the force we have from the previous study with the patient, so we knew how much we had to rub. And this is what 2 of the postdocs have been doing in the lab for the past months. Just rub the eye 1,000 times, 2,000 times, 5,000 times, 10,000 times. And then we took this eye and did the stress strain measurements. We measured corneal biomechanics. And what came out was very surprising to me. We have just last week submitted, or 2 weeks ago, submitted the abstract for ESCRS. At 10,500 repeated movements, that's the equivalent of rubbing the eye 3 times a day, heavily, for 1 full year. We couldn't find anything, no change in biomechanics whatsoever. What I want to say is, let's not get hysterical about eye rubbing. If I see a patient who rubs the eye, of course I will tell him, stop rubbing the eye. But if the patient tells me, doctor, is it okay to do a little bit like this or that? I say, it's a marathon. If you do this once or twice a week, nothing will happen. And I simply can say this with more impact now that I know that more than 10,000 rubs on a porcelain cornea don't change a thing. And just as a reminder, we are able to measure the cross-linking effect in a mouse cornea of 1 millimeter. So we know what we're doing in measuring biomechanics ex vivo. So this is something we are quite excited about, and we have to look more into it. Again, stop eye rubbing. I just touched my eye. Stop eye rubbing. but do not be too afraid for the patient. It's all within reason. And seeing this, I strongly believe that eye rubbing is a trigger, is not the cause of keratoconus. Let's look at another case. A 39-year-old lady that came from, referred by her optometrist. And sorry for the text, it was translated by my French-speaking optometrist. I think he translated it verbatim. So the question was to transplant or not, and she already had a eye drops on the left eye. And she never wore contact lenses. I'm showing you this case, and I completely left the eye rubbing. This is a very different case because this patient had a visual acuity that we couldn't even measure with glasses. She never had contact lenses, and she was on the transplantation list. Now, look at this cornea. You will see the remainder of the stroma was a little more than 100 micron. The epithelium did a fantastic job in compensating. It's at 150 microns. But what surprised me the most, we gave it a try with our contact lens specialist. And she had a scleral lens adapted, and she reached 0.8. That would be 20/25 vision. And she was happy with that vision. So whenever you can, when you have contact lens specialists, scleral lens specialists close by, even in the eye drops with the central scar, you always have two elements that make vision bad in a very thin cornea. It is the opacification and it's the irregular astigmatism. And the contact lens takes care of the irregular astigmatism. And sometimes we are even surprised seeing how high vision goes with the contact lens, because in fact, it's the astigmatism that is more disturbing than the scar in the center. So always give it a try. As you can see, it's a mixture of cases that are very different, but I hope they all can convey a very simple and clear message. The message here would be always give it a try with a contact lens if you can. Another patient that came to see me, hi Renata, a 52-year-old lady that came to see me almost 2 years ago for refractive surgery. She is a dentist, and she came with this refraction. And of course, you don't have to study rocket science to see that this probably is not really the ideal refractive candidate. And we did a topography, and this is what we saw. So very quickly, the discussion went from cosmetic refractive laser surgery to rather, I would like to see you back in 3 months. She's 52 years old, and she hasn't really noted a clear decrease in vision. I would like to see you back in 3 months. Come back. Now that lady came back with this topography, and I was wondering what happened here. This is, let me see, I think this is 3 months later. So clearly improved on the anterior surface, and I asked her, has anything changed in your life? And she said, yes, I have a newly diagnosed ovarian cancer, and I've had a total ovariectomy, and I now receive STEAR therapy, or SERM, selective estrogen receptor modulators. So she receives a medication for the ovariectomy that increases the sensitivity of the tissue to estrogen. And I've never heard of SERM or STEAR before in conjunction with the cornea. So we said, please come back in a few weeks. We need to understand what happens here. And this is how she came back 8 weeks later. Massively increased. This lady is 52 years old. And then we decided to cross-link her. I decided to cross-link her because it was clearly progressive, and I couldn't juggle this factor of this new medication. And to my greatest surprise, this is how the cornea looked several months after cross-linking. And in hindsight, I do not know what would have happened to this cornea if I hadn't cross-linked her. This would have been very interesting, but ethically impossible to not treat such a patient. I had to treat her, but this is the time course. And just to show you that we unfortunately have yet another factor that plays into the hormonal gameplay and corneal biomechanics, which is selective tissue estrogen activity regulators, STEAR. Emilio Torres, my postdoc, has presented this at ESCRS, I think in 2019, and it is a very interesting new entity. Just for you to keep in mind, whenever you have problems with endometriosis, these STEARs are also used in postmenopausal therapy. So it's not only hormone replacement, it's also STEARs. Okay, let's go on to the next. I'm very sorry, Jose. Do you know by chance how long this talk? Because I have plenty of cases, so I know how many minutes will it be in total. We'll hear about it later. Let's just continue for now. It's another case. A young woman, 19 years old. She, in fact, accompanied her brother. Her brother was 16. He has had 2 unsuccessful epi-off cross-linking procedures in Germany, and he came to see me for a 3rd CXL procedure. That's a different story, but this young woman came with her little brother. She was 19 only, holding his hand in the OR. And I chatted with her during the cross-linking of her brother and asked her, well, do you see well? And she said, oh, I see like an eagle. I said, would you mind if we put you in front of a pentacam? We do this with every family member that accompanies. And she never had glasses or contact lenses. Look at the visual acuity, which is 20/20 and above. And this is the right eye. And this is the left eye. So I cross-linked her a few weeks later. So just to remind you that even if family members are insisting on, I don't have anything, I don't see badly, and I would always put them in front of a pentacam. And in this case of a teenager, I decided to treat that patient because apparently after asking the little brother, he progressed very rapidly, and I didn't want to pick my chances. Now, when you cross-link, you might also have major surprises, and this is a surprise that Theo Seiler published a case on. This is a different lady, or was I too fast? Sorry. Theo published a case of continuous flattening over 10 years, and we also have a lady that has had bilateral long-term flattening over 10 years after a standard epi-off Dresden protocol procedure back in 2008. I still have the operating report because this is one of my very own patients. And just look at the topography between 2008 and 2018. We should make this a case report and put all the intermediate topographies within, but over 10 years, she was flattening continuously. So this is what makes it relatively hard to promise whatsoever to the patient. And this is also one of the reasons why I'm very, very, very careful in ever combining cross-linking and PRK in one go, because I do not want to be trapped with a decrease of 12 or 13 diopters here of flattening plus my wavefront-guided PRK on top of it. Okay, but these cases are well described in the literature. Yet another case. A man, a relatively young man with a far progressed cone after high drops on the right eye, very low visual acuity, never wore contact lenses. This is the Placido image, quite impressive. And this is the topography taken with the Placido-based topographer. No Kmax, but rather the radius in millimeters, huge differences. And if you want to play around with the 3D view, I think this is nice to explain to patients what a cone can do. Again, this was a patient who was on the list for a corneal transplant. And I show a second of these cases because I I simply can't believe sometimes what can be done with the scleral lens. 25-20, no kidding. 25-20 under daylight conditions with a small pupil, of course less at night, but how can you easily achieve this with a transplant? So as long as the patient is contact lens tolerant, we always start using the scleral lenses, and we are in a lucky we are in a lucky position because we have 3 individual manufacturers of scleral lenses within 80 kilometers. So we have highly trained people in companies providing all these special care lenses, and I think I have a very extreme case afterwards. So we are 25 minutes within. I just have to find out how long the talk should be because I don't want to keep you here forever. I just have to find out.
Farhad, you still
do you happen to know by chance, because I can't find out how long it should be?
Farhad, can you hear me?
I'm sorry?
Yeah, can you hear me?
Yeah, I can hear you now.
Yeah. You have time. Don't worry.
But shall we? Is it a 45-minute lecture?
It is 1 hour lecture.
Oh, okay. I try to do 45 minutes and still convey the message because everybody will be tired by then. So let's go. Let's take another case. Young man had cross-linking in April 2018. So I see the young man after roughly 8 weeks. This is unusual. I usually see them after 4 weeks and 12 weeks, but for some reason I saw him after 8 weeks. Look at this progression after 8 weeks. Well, those of you who use the Pentacam a lot would say, is this really a progression? Because what if something is disturbing the camera image that was taken by the Scheinflug camera? And indeed, if you see such changes early after cross-linking, you can never trust these Scheinflug images too much. I usually, in my Middle European setting, have to wait at least 4 to 5 months before I can fully rely on my Pentacam. Why? Because of haze and because of diffraction of light, and the haze, which is very nicely detectable in the densitometry module of the Pentacam. The haze at the same time, unfortunately, also gives us false readings of the anterior height data of the Pentacam. So after 8 weeks, I use my Pentacam all the time, but I'm more interested in the healing, and I take this densitometry module as an added-on value to what I see at the slit lamp with regards of haze. And then I adapt my steroid medication. Let's take another case, similar. 44-year-old man, and he was from Central Asia, came for a cross-linking last year. Now, look at this image, and this is the middle image is on the day of cross-linking, so in July, end of July, and the image to the left is 9 weeks later. This patient has never worn contact lenses. So we have an increase of 7-8 diopters. What has happened there? Well, we know now it is the haze, most likely due to the haze. But what I find very interesting is if you try to look at a technology that does not use a Scheinflug image, but for example, an OCT to generate the height data, then you're not facing the same problem. This is the very same patient on the same 2 days, taken with the MS39 that combines OCT and derives the corneal data from the OCT. And there you can see no massive increase. The patient seems to be stable. So looking at this in hindsight, I'm thinking, what have I done all these years if I rely on the Pentacam and the Pentacam can blindfold me? Well, that's not totally true. We have to be fair because we do not only have Pentacams, we also have placebo-based topography, right? And let me show you the next case, which is the last of this trio of cases. And that's a young man, 21 years old, cross-linking last year. Again, the same issue here. This is, oh, that's even 6 months after cross-linking, but a persistent haze. So is this a progression? Please do not forget that we might not all have an MS-39, but many of us have a placebo-based topography, and sometimes placebo-based might be a really good idea. So please always take a placebo-based image along with the Scheimpflug image. What I personally do is I take the keratography image at the initial examination. So I have a backup of the original condition of the cornea. And then if I run into something I do not like too much, I can always perform a follow-up placebo-based image. That's simply my policy, because it would take too much time to perform all these measurements, MS-39, Scheim, pentagram, and keratography at each follow-up. I only use it as a backup. But this has proven clinically quite well for me. Next case. 54-year-old man who had a cross-linking procedure in 2017. So this is one of the rare cases where we had a clearly documented progression in a patient over the age of 50. And I did an epi of, I think 9 milliwatts, 10 minutes was my routine protocol at that time. So under normal conditions, the patient should be stable, especially when the patient already has a certain age. But the patient reprogressed afterwards. It was a real failure of cross-linking in an elderly patient. So I did a second cross-linking procedure, again epi off, and during that time I always did full Dresden protocol. I didn't care how old the patient was. I did 3 milliwatts for 30 minutes in the recross-linking, and what I saw then was an additive effect. So before any cross-linking, failure after the first cross-linking, and then after the second cross-linking. And what is interesting is if you put them all together, you will see that in the end, the patient is better than in the very beginning. So it's as if we had needed more fluence, total energy for an additive effect to finally get this cone under control. I have a doctorand who is currently submitting her thesis on, I think we have 22 eyes now with repeated cross-linking, and out of these 22, 90% or even more, I think, it was either 20 or 21 eyes have done this. So worsening after epi of cross-linking, second cross-linking, better than in the very beginning. So you just had to take a detour to get to your final result. Quite interesting. So a certain apparently additive effect. This is where I would usually ask my audience whether you are tired or not, but it's hard to get feedback. But I see the questions and answers.
I have a question.
Yeah.
Can you hear me? Is Renato here, Ferry?
Hi, Renato.
Hello. So you mentioned that your protocol is epi off with 9 milliwatts, 10 minutes. Is that correct?
Yeah, in such a case, for example. Yeah.
Was that in that sister of the patient that had cross-linking, the one that you found? She said, "I see like an eagle." Probably her vision was better than 20/30 or better. And how will you approach that lady, that young girl with keratoconus? You did epi off as well, 30 milliwatt, 30 minutes, 10 minutes.
In this particular case, it was hard because I didn't really have a history of deterioration of vision. If I remember well, I for sure did epi off, and I most likely did the Dresden protocol, given that she was also a little bit myopic. So even if she would flatten, I would not drive her into hypermetropia. Under other circumstances, I look a lot at the anterior surface and at my refraction, because I want to avoid getting patients that are a little older into hypermetropia.
Yeah, maybe if you can give us a summary on how you decide which protocol you use for cross-linking. That would be very beneficial for us.
Okay, well, I don't have slides prepared for that, but my attitude has changed a lot over the past, I think, 12 months, and will probably change again a lot in the next 12 months. 12 months ago, first of all, I did only epi-off, and my go-to protocol was, or 18 months ago, was 9 milliwatts, 10 minutes. I also did a lot of Dresden protocol in younger patients or in patients that I deemed very aggressive, like ectasia after LASIK. What we have been doing a lot now, based on recent lab results, is I think that a slightly accelerated epi-off with a higher fluence, 9 milliwatts, not for 10 minutes, but for 13 minutes, 20, that's 7.2 joule, at least in the lab, showed the same biomechanical impact as the Dresden protocol. So, and we save 17 minutes. So I started using 7.2 joule in young adults that were fairly moderately progressive. But I also always looked at the refraction of the patient, because I do not want to induce a massive amount of flattening. So if I rather see the patient is at -1 and didn't have too many complaints, a relatively good vision, I might even return to the 5.44 that have been published, because 7.2 might lead to excessive flattening. So this is a certain uncertainty that we have to probably live for a number of years to go. What will change in a few months is I'm very excited about the epi-on protocol that Cosimo Mazzotta is looking into right now, and he has published data on it. We have tried in the past years to make epi-on work reliably, and we have tried to compensate for the UV attenuation, these 20%. We have tried to pulse the light, and we have others have tried to give additional oxygen. And I think what we need is to look at a combination of things. And Cosimo has done this in a very intelligent manner, because my group has published that pulse light alone doesn't give you any benefit. Increasing and compensating for the fluence doesn't give you the benefit. Why? Oxygen. A company we all know has then developed oxygen goggles, which I think the concept is really good, should work, but it's yet another piece of technology, and I do not like to add more and more complexity to it. What Cosimo has achieved is a very deep demarcation line at almost 300 microns in epi-on, using iontophoresis to bring in the riboflavin, pulse the light, but much slower than anybody else. He pulses the light at 18 milliwatts for 13 minutes. That's 7.2 joules, so high fluence, transepithelial, pulsed light, iontophoresis, and he has good results. And I'm excited about this, because this might finally be an affordable epi-on that does not require you to buy all sorts of equipment to do your cross-linking. Sorry for the very long reply. This was probably an overkill in terms of reply, Renato.
I'm going. So I think it's great to hear that you are changing, you are adopting, because in the past, the impression was that we have a one-size-fits-all cross-linking, which is the Dresden protocol, and let's use it for everybody, and we'll never change that. And I think changing, adapting, improving, evolving is key. And I would add customizing. I'm really happy to hear that you are customizing or changing your protocols according to the patient needs, and even thinking about how flattening effect you will have, considering what the patient has or not. It's really what I believe, customizing, individualizing the patient care. You've done a beautiful work with the eye rubbing machine. Beautiful work. I don't want to take time from your talk to comment on that, but I think this morning was interesting because Damien Gatinel gave a talk for the ophthalmology university here in Argentina, they have a very nice setup of webinar like the King Khaled one. So we've been learning so much over the last weeks from each other on these webinars, and I share your opinion on the concerns that eye rubbing is not the only thing, but one of the things that he pointed is the biological effect of eye rubbing is not only mechanical, because you have enzymes that are released when you rub the eye, like mild anti-inflammation that is coming, and also the temperature. And it's not only eye rubbing, is leaping over the eye at night. And I know it opened some of the thinking for me, because the importance of sleeping against the eye, pressuring the eye when it's a little bit more, the temperature is a little higher, so the cornea may get a little weaker. And since the eyelids are closed, you have a little bit of mild edema on the cornea. You have more hydration on the stroma, so everything is a little more flexible, let's say. So your model is beautiful, and I think your model made a point that eye rubbing is not the only thing, but we should take into consideration other factors beyond the mechanical of the eye rubbing, and eventually this is going to be the addressing discussion on your conclusion.
I fully agree, Renato. There is so much more to it. So each scientific study has its limitations. What we have done has the limitation that we can only simulate, as you say, the mechanical effect in a tissue that cannot react like a living tissue. That's totally true. My point was, at least it's some sort of research, because we cannot simply give strong opinions without any validation behind it. So what I want to stimulate is research on the topic, and we need much more of it. And regarding the adaptation of protocols, let me just put it in this way. Looking at my mentor, Theo Seiler, Theo was facing 2 or 3 years ago comments that he's too rigid and he's not adapting to the new protocols needed. I think he was the greatest inventor of us all, because he had the idea of bringing it. But this still means that it's a fine line between maintaining the current standard and not becoming rigid, because what I do not like is a cowboy mentality where everything and anything is tried without backup. And this is why sometimes it just takes years and years before you can really speak about a valid method. And this is why I was totally against transepithelial at that time, because I had burnt my fingers myself, and I could not trust the results that were coming out. I trust them more and more now, because they perfectly fit into everything we have learned in the past 10 years, and we've learned a lot. So I think we all are willing to evolve, but it's a thin line between maintaining what is accepted and is working, and diving into the new ones. I think you said it beautifully. Said our first aim is not to harm. Yeah, but we also want an effect. So sometimes I rather go with what I know is working than with what I think is working. That's my motto. Great.
Let's go back to your examples, so our cases.
Okay, let's do a few more. This is an interesting case. This is a gentleman with a progressive globe, and I think, yeah, this will be my second last case. Again, a very low visual acuity referred by the optometrist, wears scleral lenses. Now look at this eye. Nothing is happening. Let's try again. I think it froze. Here. That's the eye. That's the keratoglobus. And if you look at the imaging, it is quite impressive. Now, what we have done in this case is, again, we've tried with the contact lens first. The patient had a documented history of progression, knowing that no topographer in the world can easily take reproducible images, but we had a history of more than 10 years, and the steepness of the cornea all pointed into one direction, which is slowly progressive deterioration. So we had two problems. We had an extremely thin cornea that needed some stabilization, and we needed better vision. Now for better vision, let me just show you this. This is a normal scleral lens. And as I told you, we have 3 companies in the country, and this is the custom-made lens that Falco did. I have never seen such a thing. Yeah. So this is the contact lens that allows the patient to see. Now you cannot produce such a lens in a conventional way anymore. You have to take, and the visual acuity is unbelievable. It's 20/20 with that lens. You have to take an imprint of the eye. It's like adapting a prosthetic. This is the initial molding procedure the patient has to undergo to get a customized scleral lens, where the K-max reading, I think, were close to 1. I can't remember. They were incredible. So there was no way to produce a normal contact lens, normal scleral lens even. They had to go this way, and this was the lens seeing from the side.
Can you please describe what's going on in this blue image here? What is?
If I understand well, it's a soft tissue that simply takes an imprint of the surface and then hardens. Like where do we use this? The dentists use something similar when you need a filling, right? You bite on this mold, and then it polymerizes and keeps its structure. And this is the molding basis for generation of the contact lens. It's totally crazy, yeah. We've only used it once now in the past years. We only had one case that was simply too extreme to be fitted with any type of conventional scleral lens. This was the anterior segment image of that patient. Now, at the same time, the patient was progressive, so the question was, can we cross-link such a cornea? And we started looking into this. Now, just as a reminder, these are 3 of the main CXL modifications that have been used in the past years for very thin corneas. So the first one was swell the cornea with hypoosmolaric solution. This is what we have done in Switzerland back in 2009. Then a few years later, Susan Jacobs came up with another idea of a contact lens on the eye. And Cosimo Mazzotta said some years ago, why don't we just leave epithelial islands where the cornea is the thinnest? Now, let's look at these concepts. None of these concepts, including ours, none of these concepts is perfect. The swelling is probably the one that is used by most people. Swell the cornea, osmotic gradient. The problem here is not the biomechanical response. Gregor Wollensak has published a paper a few months ago showing that the biomechanics in a swollen cornea is good. The problem is it is highly unpredictable in terms of increase of thickness. Some patients swell a lot, others simply do not swell. So you never know what you're facing. It's a black box. So I've been, of course, using this for many years, but I was not too happy about this. And then Susan Jacobs came up with her idea, and we liked it a lot. So she had a very nice idea of putting a contact lens on top of a thin cornea. But just a year before, we discovered oxygen as one element. So we were really a little concerned that even though you might have a more shallow cross-linking, what about the oxygen diffusion into the stroma? And in fact, if you put a contact lens on top, you will find 2 papers in the literature, one from Sabine Kling from our group back in 2015. This one has not been discovered really because we have buried our contact lens data deep into the rest of the manuscript, but we had a 30% decrease in efficacy, and the exact same thing by Gregor Wollensak. So when he did contact lens assisted cross-linking, he had an effect, but 1/3 less than in standard cross-linking. Why? Because you have an oxygen barrier. So it works, but it is suboptimal also. The swelling is suboptimal, this one is suboptimal. The Cosimo Mazzotta one is also suboptimal because you have then different different degrees of UV attenuation. You have haze in a strange pattern. Then we went back to the books and said, okay, let's look at this. Currently, left side, only stroma 400, that's easy. We cross-link down to 70 microns over the endothelium with our standard procedure. And on the right side, a thin cornea, what do we do now? We have a problem, so we increase thickness by swelling the cornea, by putting a contact lens on it, by leaving epithelium. It all modifies thickness. If you think about other factors that you could modify to individualize the effect in a patient, you could modify riboflavin. You could say, instead of using 0.1% riboflavin, I use 0.2, 3, 4, or 5, because then you have more riboflavin in the superior cornea, anterior cornea, and you will have more effect anteriorly and less effect in the depth. But this would mean that you would have to live with 15 different riboflavin solutions and would have a whole stock like we do for our IOLs. This doesn't make sense from a practical standpoint. What makes most sense, play with the total energy. Adapt the total energy to your thickness. Keep it simple. Which means that instead of doing Dresden protocol or any other accelerated 5.4, instead of doing 5.4 joule, we have to adapt the total joule to every individual thickness. And we've been doing this in the past years based on 3 milliwatts and 9 milliwatts. And we have published the algorithm in 2017. It's a quite complex algorithm, but it takes into account oxygen diffusion, riboflavin distribution. And all these are things we did not know back in 2009. So we had all the elements together to really individualize cross-linking. This is not customized cross-linking. Customized cross-linking means a lot of energy over the cone, less energy in the periphery. This one here is the same energy everywhere, but adapted to the thickness. And so we did a prospective interventional study. And we now have 47 eyes with a 1-year follow-up. The thinnest cornea we've treated was 214 microns of stroma. And this is a thickness that you can never reach with swelling a cornea, for example. And we stayed below 400. And what we have done is, so we removed the epithelium, measure thickness, then put in riboflavin. And after 20 minutes of riboflavin, we measure thickness one more time. And this is the value we take. Based on this value, let's say 280 microns, we then know, oh, at 280 microns, I need to switch on my lamp for, let's say, 8 minutes, 50 seconds to have a fluence that brings the demarcation line down to 70 microns in front of the endothelium. And we've done this now, and what surprises me a little bit is the success rate at 1 year, because it's at almost 90%. I did not expect this. I expected 70% maybe, because we are dealing with extreme corneas. But it seems to work well, and we have just submitted this work. So we are able to treat a cornea like the one above, 220 microns of stroma. And that's quite extreme. You can see the demarcation line here. So not a single case of endothelial decompensation and a high success rate. What I like about this is you do not need a fancy technology. You can do this, and we decided not to patent whatsoever. This will be a publicly available algorithm. Anybody can do this with any type of machine. So we wanted to go back to the most simple application. Any machine can do 3 milliwatts. Many machines can do 9 milliwatts. That's all you need. 9 is nicer because we adapted it to 9 milliwatts too. Then you have to spend less time on it. And we cross-linked that case. We cross-linked that keratoglobus case. And with a 2-year follow-up, the patient has been stable. As far as I can believe, topography is taken in such a cornea. But the patient seems to be stable, and vision is really good. I think in this particular case, no, that's a different case. Sorry, it's mixing up now. I think I will stop here. I would have had a few more slides, like Terrien's disease that can also be treated by cross-linking, but I think we could stop here. Would you agree, Jose?
Yes, thank you, Farhad. Now, if you guys can, there are questions, open the Q&A and you can answer directly the questions that you see there. Both of you guys can answer the questions.
Okay. I'm just trying to
There is
find
a question
out.
about recross linking. What are the
Um,
limitations in terms of keratometry and refraction, etc.? From
I'm just
Ali
trying to
Aujai.
find. I don't see it. Could you read it? Because I don't see it.
Yes. Can you hear me?
Yeah.
Yes, Renato, we can hear you very well.
So there is a question about the limits for recross linking, for repeating cross linking, and what are the limitations and concerns on repeating cross linking? What would you advise? That's the question from Ali Auraji.
I
Sorry
see.
to say your name.
Do you want to start, Renato?
Well, I've been doing repeating cases of cross-linking in some cases, not in many cases, in some cases. All these cases are patients that are progressing too much and they keep progressing after cross-linking. And one of the convergent points goes back to the eye rubbing issue, because those patients, they really rub your eyes. Sometimes they say, I'm not rubbing the eye, doctor, with their hand on the eye. So my first topic is tell really the patient not to rub the eye. But some patients are really progressing despite of the rubbing, and those are the patients that have what I call as the real keratoconus. The real progressive keratoconus is more. These are the genetic keratoconus, if we can say something like that. So these patients, I would try to do more, going back to the 30 minutes, 3 milliwatts protocol, because it's more proven to be correct. So if I have to repeat cross-linking, I go back to the standard Dresden protocol. But usually I have moved to the fast cross-linking with 9 milliwatts per 10 minutes as the standard since the first description of this new model for the new lamps, etc. So what's your opinion on? And probably you do much more cross-linking than I do, and people benefit from your answer.
Well, I fully agree. The second time we need something that is probably gives us the biggest likelihood, which until now was the Dresden protocol. I see two major issues. One, we fortunately do not have that much in Switzerland, which is a problem with the post-op haze. If you do a repeated cross-linking, we are luckily not facing too many issues there. What I try to do is increase the total fluence quite massively. And so if we do a first procedure that fails, let's say 9 milliwatts, 10 minutes, or 3 milliwatts for 30, this always is 5.4 joule. But in a recross-linking, if it's a young patient, in an aggressive case, even after 6 months, I will not give concrete numbers because we still have to validate them, but I go way above 5.4 joule in the second cross-linking. So the cumulative will be much more than 2 times 5.4. It will be way higher. And we have had quite good results, even quite a bit of flattening in these cases. In other words, what I've shown you before, Renato, was the adaptation of the fluence going thinner and thinner. We did the same thing, going thicker and thicker. So if on top of that, we had a cornea that had 440 or 50 microns, we went way up with the fluence, because even those cases sometimes fail, maybe because the relative portion of cross-linked cornea is worse than a cornea that is relatively thick to begin with. So we are trying to increase overall fluence.
What do you think about it came to my mind in terms of thicker corneas? of PTK for removing the epithelium. What do you think about that? And the role of epithelial thickness measurements with the OCT in your daily routine for cross-linking?
I have the MS-39 for a few months. I don't have as much experience with it as Jose does, but I look at every single case and I try to wrap my mind around which factor is the most important for me in terms of local thinning and thickening over time. What I think is highly interesting is what Miguel Requique is doing with trans PTK, trying to use it for a partially refractive correction. I haven't used it completely yet. I've used it only a few selected times, but I'd rather still do cross-linking it than a wavefront guided PRK later on.
There's a question, how much contact lens changes may result in epithelial thickness? From Saad Alberbi.
How much of contact is it?
How much contact lens corneal changes may be the result of epithelial thickness changes? What do you think on this? This is a good point because contact lens can change the epithelium. That's exactly what the contact lens work.
Exactly. This is the concept orthokeratology is using, right? So I think it is a lot of epithelial changes. So the corneal warpage I've shown you was taken on a Scheimpflug imaging system. It would be very interesting to understand the effect of corneal warpage on an OCT-based system and compare the two. This is something our friends in optometry should do once to give us some more standardized values. But I don't know how much of the warpage, maybe, do you know something about this, Renato? How much of the warpage is due to epithelium rather?
I think most of the warpage is epithelium. Dan Reinstein has published on the high frequency ultrasound. But the interesting thing is that epithelial thickness, now that we can measure, we should do it for some of the cases that you shown in the early 3 months after cross-linking that you have some steepening. I really would believe that this is because of the epithelium that's very thin at this point. Once the epithelium thickens, you have the flattening effect. So understanding what I call as a segmental tomography is critical for us to see the effect on the cornea, on the corneal shape. It's not only the front surface. I agree that the placido maps are still important for us, especially when we have this type of hazy structure of the cornea, but is beyond the surface, beyond the thickness of the cornea. We have to see the epithelial thickness. So epithelial thickness is a new dimension for understanding the cornea, and the OCT are the best tools because we don't need to touch the eye. It's much quicker. And beautiful. There is a question, Dr. Osman. He thanks you for the great presentation, and he asks, what's the role of IS value to exclude suspicious cornea for doing LASIK? Do you think it's predictable to rely on it? And how do you measure accurately from the map or from the screen itself?
Do you understand the last part of the question, from the map or from the screen itself?
I think maybe he's asking how you measure it. If you're just using a number, or if you're looking at the map on the practice to calculate the IS value.
Well, I think this is a question any of us would have to answer. Anybody who was doing refractive laser surgery. So the inferior superior asymmetry as a value to exclude suspicious corneas. I think we have the right person here as the moderator right now to give us some insights. How is this the only factor you look at, Renato, when you plan a LASIK, or we have quite some indices there besides IS. So how large do you see the value of IS in all this?
IS is the first. Yaron Rabinovich published in 1989 this IS concept, and the best way of doing it is from the map itself. If you don't have it printed out from your topographer, you just print the maps with the numbers, and you get the average numbers on the 3 millimeters above and below the center of the map, and you do the average. And you can just look at this on the vertical, it gives you a very reliable number as well. Every time somebody asks me about a parameter, I like the ROC curves, sensitivity and specificity. And if you see ROC curves for ectasia prediction, we have 3,000 stable LASIK in one side and 100 ectasia cases in the other side, and the sensitivity is 20% of abnormalities in the pre-op of ectasia patients, and the specificity will be 87%. So it means if you obey that rule, you may be specific for that scenario, but you are not doing surgery in 13% of cases that could benefit from LASIK on a stable outcome for 2 years. But the problem is that you will still have 80% of ectasia cases with low IS value. So, and that's why we have to go beyond. And it's always been the concept, beyond but not over. We have to think about asymmetry, but we have to look at pachymetry, elevation, and going even beyond. If you look at the BAD-D, the sensitivity is about 60%. And if you go to the PRFI, which is a random forest index from the pentacam, it goes to 75%. And if you combine the data with the impact from surgery, it goes to 95%. So we still are getting better and better, and we have to acknowledge that nothing is perfect. It's a measure of risk, but we have to go beyond the surface. And it's pretty much clear on the status of understanding of ectasia susceptibility.
That was a nice response.
I think we have two more questions.
Please.
Let's see. We have sorry, here.
We have many questions, but I think that we have time for two more questions.
Epi-off or epi-on, is there a special indication for each? I think that's a good question. It goes a little bit into what we have been discussing before, Renato, about we need a more individualized or customized approach for patients in the future. And I think epi-off or epi-on plays a little bit into it. As per today, I already use epi-on in quite a few instances. I use it if I have a very uncompliant, low cooperation patient where the risk of eye rubbing infection post-op is high for me. Then I go for epi-on. But I think in the near future, with epi-on becoming more and more efficient, I could see where you use epi-on in milder forms of keratoconus to start with, less aggressive, little older patients. So let's say a 32-year-old who has said, yeah, there has been some changes in the past 12 months. But I still see relatively well, and it was not aggressive, and you see a documented but not very aggressive progression. This, I think, would be an ideal epi-on case. Epi-off, for now, I think still has more chances of being efficient, but this might change. This might change in the near future. For now, I would only do epi-on if there is a compliance issue, and if you are facing a subtle cone where you're asking yourself, is the risk of the procedure justified in this special case? Maybe even a 30% lesser efficacy would already be enough in this patient.
Yeah, if I really am looking forward to seeing a good protocol for the epi-on, because some people would come to the point that would compare cross-linking with like a vaccine, something to give to everybody so that people be immune to the disease. Mm-hmm. And I would say that we are not close to that with the current epi-off protocols. Epi-off mm-hmm. protocols, they cause pain and they delay the healing, and the first month you have worsening. But if you have a good epi-on procedure, that may be close to use that as a vaccine for the susceptible cases. So you screen the susceptible cases and you do the treatment for preventing the problem. You know, we have it's true. Preventing is better than treating.
Yeah. And you're absolutely right. So maybe someday we will tell the patient we have this bilateral procedure that has a very low risk profile, and it might increase your likelihood of staying healthy. And who knows, maybe also even an infection. Maybe we started looking into this in an ex vivo model. What happens if you precondition a cornea with cross-linking? Is the infection, a bacteria spreading with the same speed as in a non-pre-treated epi-on cross-linked cornea? So really, as a vaccine, it might be someday.
There's a question from Switzerland, from Dr. Martin
Larcher.
Larcher.
Oh, nice.
He's asking about 6 or 8 millimeters in the center of the cross-linking over the affected cone.
Guten Abend, Herr Larcher. So, do you perform cross-linking over total diameter, or do you center? Well, if we center it over the affected cone, for example, over the steepest posterior elevation, then we would probably go into, probably the question is aiming at customized cross-linking. Yes, that would be a means to induce more flattening effect. And here again, I think customized will be one tool amongst many that has to be used in specific patients. Maybe you want a strong flattening effect in a certain patient. Maybe you want something totally different in another. So for now, I'm using a uniform irradiation mode, but I adapt it to the individual patient's fluence. And just to let you know, what I've shown you before with these thin corneas was initially based on 5.4 Joule at 400. And now we have a second phase study running where we base it at 10 Joule for 400. So way, way, way higher. So this is another way of adapting. So I do not use customized where I censor. I use a uniform fluence that is individualized for now.
So the question from Hamad is my question. Dr. Ahmad El Zahug. He asked when the nomogram for individualized cross-linking will be available.
So the manuscript is ready. It's been sent out to the remaining co-authors for final approval, and we will submit in the next days. Hopefully, we will have a smooth reviewing process, and then it should be out in September. Hopefully, by ESCRS it should be out. And as we said, we didn't protect anything. You will have a table, and you can use the nomogram with any machine. The slit lamp based cross-linking that we developed will have it integrated, but that's pure convenience. So you don't have to look onto a table. You can just give the input of the thickness. But you will be able to do this with any type of cross-linking machine.
Great. So Dr. Yash Gala asked, ideally the corneal biomechanics are stable with the growing age of 21 years old. So it's ideal to do it earlier than as changes yet to occur. So do you consider cross-linking as an early indication?
So I think it's important to stress to the fact that the older we get, the less the likelihood of progression. But we have all seen patients over the age of 40 and even 50 years that are clearly progressive. It's just very, very rare. So your likelihood of stabilization increases, but it is never 100%. Your likelihood of worsening is never 0%. So I wouldn't see a clear cutoff at 21 years. The younger, the typically more aggressive, but it can occur in many different ages, stages of your life.
There's a question regarding ICL or phakic IOLs for after cross-linking. What's your recommendation? That's a good point.
Mm-hmm. Well, I'm also curious to hear your opinion. Well, if once the cornea is stable, I don't really care too much whether it was an extremely thin cornea or not so thin cornea. If there, for example, is a relatively high symmetric portion of your irregular astigmatism that could be somehow corrected with the toric ICL, then it might make sense to use one.
Yeah, I agree. If the patient has good vision on the phoropter with first cylindrical lenses, you do well with the, and maybe 3 months of stability, that's going to be very reasonable. And of course, these patients have to be understanding they have a disease that can progress regarding everything.
Absolutely.
So there is a patient with Down's, Dr. Osama Giledi.
Oh,
And
hello, Zama.
he's asking about a patient with Down syndrome, 20 years old, developed acute eye drops and 3 months ago improved. The other eye, early keratoconus, steep 51, flat 48, unable to do pentacam, very difficult because of Down syndrome. Eye rubbing is also an issue. Should I cross-link her? Good eye. What about worse eye? Can I do cross-linking? Should be a good patient for corneal graft or and gross eye rubbing. Thanks very much.
So my answer to this would be, Renato, you have created this wonderful initiative about the violet June, right? Violet June. We have tried to do something with the Light for Sight Foundation some time ago, where we specifically look into cross-linking for children, and we looked a lot into Down syndrome. What we had developed is an approach that I still use, a stepwise approach that goes along with the compliance of the patient. Now, this patient clearly is very little compliant, so I think I would do a bilateral epi-on under general anesthesia. And of course, less cross-linking effect, but intact epithelium, so hopefully less eye rubbing. And now, one measure that we could, that Dr. Giledi could then consider in the first 4 days. We have done this a few times over all these years. It sounds terrible, but orthopedic surgeons, when they do shoulder surgery, there are special casts provided by 3M that block you in this position. It's not fun, but if the parents go with it and stay with the child for 3 or 4 days, the child simply cannot reach and drop. Plus epi-on for 3 or 4 days, and then the urge to rub is much less, because the punctate keratitis that you get with every epi-on procedure will be over. So this is what we've been doing: transepithelial and special precautions not to rub the eyes in the first few days.
Yeah, the question about what is your protocol for routine crossing? Which drops you use? You use antibiotics, steroids, non-steroids?
We have looked a lot into it in the past 2 years, and I had an epiphany talking to Shadi Awad and Jerry Ten. They have convinced me, and now I would say publicly, this is my personal opinion, and this is no guideline, but I'm using NSAR on the open surface since 5 years. We've done a few hundred cross-link cases like that, and I've never experienced any problem by combining steroids and NSAR. We are putting together a small methodology paper, technique paper, and we'll submit it soon. The idea is that if you look at the inflammatory cascade, the reason why NSAR might be so dangerous is because they are a very effective painkiller also, so patients used to overdose them. But at the same time, the slightly anesthetic effect is something beneficial if there is no abuse. And if you block the leukotriene and the prostaglandin pathway at the same time, which you would do if you give steroids and NSAR at the same time, then you do not activate MMP9, so no melting. So we use the combination of both since 2015 for 48 hours, and it has proven extremely successful. Patients come in the next day, and I can hardly see which eye has been treated by cross-linking, because it's a white eye, no pain, and we haven't seen any side effects. And I think we are at almost 500 cases now, so I feel really comfortable putting this on a larger platform and publishing it as my personal opinion, because it is a little contrary to what the AAO is having in its guidelines right now.
So there is a question from Dr. Hossam Ziada from Egypt. Hello, Hossam. He is asking about epithelial mapping in the role of diagnosis of irregular cornea. Maybe you can briefly comment on that.
I think
That's
I
a
think
big talk.
I think Jose Vargas has done much more in it than I did. So I think that's a perfect question for Jose.
We don't have that much experience with the mapping and to decide about irregular corneas. So I think that the right question will come either from Renato or from Dan. We got more experience on the working with different kind of pathologies instead of mapping the cornea for keratoconus. We almost have the same machine from the same time as you. We got it on November.
Oh, I see.
Yeah,
Well,
yeah.
then-
So I had the chance to work in many mapping from keratoconus patients until now.
Yeah.
Well, so I may add, I started using epithelial thickness in 2013 with the ArtiView.
Okay.
So I use it for every case, and I can tell you it's always about beyond but not over. You need that to understand a lot about the healing of the cornea. You've seen cases after surface ablation in the first month, they are not seeing well, and you take the epithelial thickness, you have a lot of information that the epithelium is still healing. It's very thin and very irregular, too many colors on the map. And once the epithelium is like more on the thicker side, you have a better vision. It's also going to help you for undercorrections and regressions that you can have. So I think epithelial thickness is a new dimension for understanding. I really believe it's part of the armamentarium of any refractive and therapeutic keratoconus surgery. So it's very beneficial for us. And I see Dan's talk always as something inspiring. But in the past, he was the only guy able to do epithelial thickness maps. So every case I have, I should send to him to say, can I do surgery or not, based on his concepts. And this is also an interesting scenario when I give my topics of recommendation with things that I am working close to the early development, like the biomechanical measurements with any machine. So you have to understand the benefits and the limitations. And truly today, I believe epithelial thickness is part of the armamentarium, but it has to be integrated. It's not the only thing you should do. It has to be my concept today is multimodal approach, and ocular wavefront is also going to improve your understanding, the corneal shape and the biomechanics of the cornea integrated. And hopefully one day we'll have the biomechanical tomography and epithelial thickness integrated into the algorithm for ectasia detection. That's what we aim for.
It's amazing how dynamic this field is. After I've been in it for a few years now, and there are still new factors coming up all the time.
Yeah, it's a evolution in revolution. There is a question that's easy one. What's your recommendation for contact lens in the era of trans PRK? How many days the patient should stop contact lens before surgery? I think Dr. Saad is asking about refractive surgery, PRK, trans-epi PRK.
Well, I currently do probably 90% trans PRK, and I usually am totally fine with 2 weeks. The extreme case I've shown before is just to remind us that even after 2 weeks you will have a certain amount of warpage. But practically speaking, I've never burned my fingers asking for 2 full weeks. That should be totally sufficient.
I think we went through all the questions.
Yes, we did. Guys, I think there is almost 2 hours, 1 hour and 4 minutes. Yes.
Okay.
Farhad, Renato, once again, thank you so much. On behalf of King Khaled Hospital, we want to thank you for your time, for such a beautiful lecture and beautiful comments. Hopefully we will see you guys again very soon.
That would be nice.
Yes, yes, in person.
Yes, absolutely.
On the other side of the curve, as people are saying now.
Yes, hopefully.
Yes, yes. And so once again, thank you so much. And thank you for all people that stay with us for almost 3 hours. We appreciate your time and thank you so much for being with us. My regards to
Thanks again, everybody. It was quite an experience.
Great.
Thank
Good
you,
to see you.
Farhad,
Good to see you.
and thank you, Renato. It has been a great chance for all of us to meet you again and listen to your experiences. And we appreciate your participation in this very important activity of KKH, the Global Education Forum. We've taken a lot of your time and we are all very appreciative. And as Jose said, we look forward to welcoming you both physically at KKH. Take care.
Thank you for the invite. Thank you very much. Take care. Bye-bye.
Take care. Good to see you.
Good to see you.
Good to see you too. Thank you.
Bye-bye.
Thank you.